Thank you for joining me. So we're going to go through care standards meeting number 2. So things that we're going to cover today are things like the restraint policy, duty of candour, patient waiting times, chaperone procedure, working without chairside support, safety alerts policy and arrangements, reporting safety incidents, adverse reaction to drugs, safeguarding and was not brought, female genital mutilation reporting, the early detection and management of oral cancer, direct access for DCPs, domiciliary care, notification to a regulator when required, and emotional care and support policy. Now, from a restraint perspective, the practice policies that we actually won't restrain our patients. Now, there is something called clinical holding, but that does require postgraduate training in special care dentistry, and it's out of our scope of practice. If a patient has learning disabilities or mental ill health, we'll take all steps necessary to ease their discomfort. Now, that might basically be giving more time for explanations about treatment, gradually introducing the patient to more advanced treatments as required, being prepared to stop appointments early if the patient's not feeling so well, giving the patients ways to feel in control of an appointment, such as hold up your hand if your patient needs to stop, and then offer sedation options at other practices such as RA, oral sedation or IV sedation with anaesthetist. We could also obviously try teaching the patient some relaxation techniques as well. Now, duty of candour is all about basically being open, honest and supportive with a patient. Now, not every treatment will always go as intended. Now, if that is the case, we need to make sure that we notify the relevant person, who is usually the patient, that something has occurred, and then basically we do that as soon as we possibly can do. We need to give an apology in person. We need to provide the relevant person with all the reasonable practical and emotional support necessary to help overcome basically the physical, psychological and emotional impact of an incident. We need to basically be jargon free and give a step-by-step account of all the facts that we know about the incident, and basically this is to the relevant person that needs to hear. We need to give the information in a way that the patient understands, and obviously you can have advocates or interpreters there if necessary. Advise the person what further inquiries are appropriate, and then give them reasonable opportunities to be involved as much as they wish to be in any inquiries. Explain to the relevant person any new information may come out during the course of the inquiries, and obviously keep them informed of this new information. Provide a single point of contact for the patient and keep the case discussion on an ongoing basis until they're satisfied that all the relevant information has been disclosed to them. So we need to basically provide them with the outcomes and results of inquiries and investigations in writing to the relevant persons should they wish to receive them. And we obviously need to make sure that correspondence to the relevant person is done in an appropriate and timely manner. And obviously keep a record of all these communications. Okay, so chaperone policy, we need to make sure that we provide a safe, supportive environment for patients. When we're examining or treating patients, we prefer to have somebody else in the room, preferably a GDC registered team member. The primary purpose of having a chaperone is to assist in the event of a medical emergency, but also the chaperone is going to assist us They're going to provide emotional comfort and reassurance for the patient, especially while you're concentrating as a dentist. That can be really useful if the nurse basically is looking out for little telltales there that the patient's struggling a little bit and obviously just need to take a break for a moment. Chaperone can sometimes act as an interpreter. Can be a third party in a case where they need to provide evidence about a treatment or appointment and basically what's happened in a scenario. In very exceptional circumstances, it's not always possible to have a chaperone there. For example, this could be on out of hours care, but also these need to be risk assessed basically before treating the patient. Now, working without chairside report, there is a full basically policy on this. Now, it's quite common for a dental hygienist and therapist to work without a chairside assistance. Now, I'm not going to go over this too much because actually we've always believed that basically a hygienist therapist should have basically nursing support. So again, I'm not going to spend too much time going over this one. Now, safety alerts. Obviously, we need to make sure the practice stays up to date about any changes. Alerts, basically, we need to make sure that any that come through, we need to make sure that they come to attention of all the relevant team members, and if there are any actions that are needed, we need to make sure that they're discussed either on a one-to-one or a full practice meeting. We are signed up to the alerts based with the MRHA and the NHS Central Alerting System. When an alert is received, we follow any actions required in the time frame that's basically issued with the alert. Relevant safety alerts to us are basically stored in folder 6 and are basically distributed to any involved team members. Things that basically that come to mind that we have had, there was a few instances in the hospital where the oxygen supply hadn't been turned on both valves, and the patients basically hadn't been receiving the oxygen they were supposed to because the valve was still turned off. Another one was the recall on, say, the auto injectors for adrenaline. Safety incidents policy. Obviously, accidents can happen. We need to make sure that they are recorded. Anything that basically does happen needs to be reviewed and investigated by Nicola and myself. He'll make sure basically that actions taken to minimise the harm from the incident. That's basically to the parties that are involved, but also trying to obviously making sure that prevent it from reoccurring and that relevant improvements are basically made. That'd also apply actually for near misses too. So, for example, there was a patient and one of the stair nosings had come a little bit loose. The patient did trip but didn't hurt themselves. Now, obviously, that would be classified as a near miss. Obviously, everyone's very grateful no one's been injured, but obviously we'd need to make sure that stair nosing was repaired straight away. Adverse reactions to drugs. There is a whole protocol in place basically for monitoring basically an adverse reaction to drugs and reporting of those to the appropriate bodies, and that's using something called a yellow card. Now, safeguarding. Safeguarding is obviously a really serious and very, very important protocol that we've got at the practice. So we must always protect children and adults at risk of abuse and neglect. If we identify, we need to obviously make sure that we have a really effective response. Now that basically includes reporting any safeguarding issues to myself as the safeguarding lead for the practice. In terms of basically definitions, a child is defined as a person under the age of 18. An adult at risk is any adult who has needs care and support for any reason of mental or other health disability, age or illness. And that's actually independent of whether or not the local authority is meeting those needs. Now, in terms of basically phrases, adult at risk actually replaces the word vulnerable adult, but quite often you'll see the two are used interchangeably. As you're aware, as a team, we need to basically maintain, obviously, our eyes out for basically signs of needing for safeguarding, but also keeping our information up to date. So using things like ProDental CPD to make sure our knowledge is up to date for things and signs of abuse in basically children and vulnerable adults. Any suspicions and allegations of abuse are taken really seriously and obviously will be dealt with very swiftly and appropriately. Any concerns, as I've already stated, need to be reported to myself, and we have a whole policy and procedure in place basically for how that's dealt with. If female genital mutilation is suspected, we do actually have a policy independently on that on FGM too. Now there is a good video on basically safeguarding. This is actually done in a medical setting, but I won't go through the full video now because it's about 5 minutes, but obviously you will have access to the link for this one.
Everyone plays a vital role through the job that they do. As a GP, I rely heavily on the whole practice team to work in partnership with our...
In terms of further safeguarding advice, a chaperone is always needed to be present when treating a child or a vulnerable adult, and obviously we have a chaperone policy on that. Any team members that are working with children or vulnerable adults need to have an appropriate DBS check, and obviously we wouldn't employ anybody who had been barred from working with treating children or adults at risk. There is actually something else called was not brought. Now, was not brought is really important basically for identifying neglect. If, for example, you had a child or a vulnerable adult and there were several missed appointments, it would actually be quite easy for the clinician not to see that the child had missed those appointments. So this is actually one that's really important for reception to pick up. So young child basically needed some treatment doing, but repeatedly basically had appointments cancelled or didn't attend. Sometimes that would be an indication to come and have a chat with myself, and obviously we'd make an assessment whether or not we needed to activate some of the safeguarding protocols for that child. Female genital mutilation is illegal in England and Wales. If there are any cases where basically there's reason to believe that FGM is going to take place or has taken place, you certainly need to come and see myself, and basically would follow the protocol that's in place for that. In terms of contacts for safeguarding, the practice has everything already recorded down, and it's a very clear pathways actually for both children and for vulnerable adults. If there is a concern about a staff member that works with vulnerable adults or children, there is actually a separate pathway, and that's through something called LARDO. This is actually the flowchart for safeguarding, and this is actually available in the surgeries. Okay, moving on to early detection of oral cancer. Oral cancer cases are actually pretty high. The average age is men and women about 45 and older. Survival rate, unfortunately, is not too great, so the sooner we can basically pick it up, the better. Lifetime risk of developing oral cancer is 1 in 93 for men and 1 in 186 for women. So basically, and it's also studies have shown that 4 out of 5 people in the UK don't know the symptoms of mouth cancer. So obviously we need to make sure that we provide as much education as we can do. So oral cancer risk factors. Oral cancer is more prevalent in certain sectors of the populations because of demographic, lifestyle and medical reasons. Again, most cases men and women over 45. Those who smoke, chew or inhale tobacco are at the most risk. It's also higher for those who basically regularly drink alcohol, especially spirits. Now, interestingly, if you combine tobacco and alcohol together, you actually get about 30 times increased risk. So the patients that smoke and drink heavily are at a significantly higher risk of cancer. Identifying high risk. Patients basically can be identified as high risk by careful medical history taken, so asking things about tobacco and alcohol consumption. Also, such medical conditions, things like lichen planus, can have a slight increased prevalence for oral cancer, previous experience for oral cancer, and also a little bit about diet and lifestyle. Yeah, again, it's really important to remember that 25% of all victims have no identifiable risk factors. So every single patient needs checking for oral cancer. It's not just the ones that basically are the heavy smokers. In terms of actually oral cancer screening, we need to make sure that we record that in the patient's notes. And actually photography is really useful, and that just to get that across the referral, and hopefully the hospital can see whether or not there's been any changes there as well. In terms of actually referral, primary care basically is all about just recording data, and secondary care is about providing the diagnosis. So if lesions are basically look like they've probably got an innocent cause, we can probably just basically arrange to review the patient to see whether or not the area has settled and it's actually it's already resolved. If basically, on the other hand, the patient, it looks like it's of high risk, then obviously we want to be activating the urgent pathway for referral. In terms of our role in oral cancer, obviously we're in a really great position because we get to see the patients quite frequently. We get to basically ask the questions that increase their risk factors. We get to provide oral examinations to basically identify any lesions that we think are suspect. But obviously we can provide as much education to the patients as possible and try and reduce their risk wherever we can. This is a little table again. I'm not going to go through every one, but it's the sort of thing that we're screening for and the areas that we're looking at when basically we provide a dental examination. There is a video that's very good actually on YouTube for checking for oral cancer. Again, we're going to provide the link for this rather than actually going through the whole video. So it just shows basically checking
taking note of any asymmetry,
looking for asymmetry, etc. Then providing
special attention to the presence of a lesion with a history of poor.
Okay, notifications to the CQC and the ICO. There are a few timescales basically for when we have to write to the CQC. Again, don't think I particularly need to go through all of these, but please be aware there is a policy. If we just basically pick one of them out, so if there's an incident reported to or investigated by the police, that would come under Regulation 18. Obviously, they would need to be informed without delay. If it was just basically a change to the provider's statement of purpose, that would be Regulation 12, and we'd need to provide that within 28 days. The ICO, so that's the who governs information, a personal data breach that poses a risk to people. The timescale for that under the GDPR policy will be 72 hours of becoming aware of the breach. Okay, emotional care and support. Obviously, as a practice, we need to make sure that we provide caring and compassionate attitude, and we try and build those positive relationships with people that use the services of the practice. We want to spend time talking to patients and obviously get to know them. And we also need to obviously try and be aware of the person's personal preferences, because we need to make sure that we can try and respect their habits, their cultures, faith and backgrounds. There are a few obviously key areas. If there's managing patients that are in pain, distress and discomfort, we need to make sure that we try and respond to them in a timely and appropriate way. So try and see emergencies as soon as possible. Give assistance to patients who have an emergency out of working hours where we can do. So that might be being able to get in touch with us and providing assistance wherever possible. Provide effective and comfortable local anaesthesia, so a patient comes in with pain, we make sure that we get them nice and numb. And give them post-procedural and pain management advice where appropriate, so they've had a tooth out, what sort of painkillers they can take, and the dosages of those. Respond appropriately if a patient's suffering from distress or discomfort before, during or after treatment. So it's basically just making sure that we're looking after the best interests of the patient and caring for them. We also need to provide information on how patients can receive additional care and support outside the practice if need be. In terms of other bits, support networks and advocacy, we basically support patients when necessary to use the support networks that are out there to help with the rest of their well-being. We have got leaflets that are available to give patients on community and advocacy services, and obviously there's a couple of links just below there as well for reference. Supporting patients with additional needs. We work with patients with additional needs, and that can include things like patients that are in the last 12 months of their life, people at risk of developing a long-term condition, people that have learning difficulties or disabilities, people with addictions, and also carers. When it comes to treating children, we need to consider their intellect level and emotional, social maturity as well, to make sure that we provide a child-centred approach to them. Very often, parents or carers are actively included in this approach to keep them fully informed and provide optimal support for the child. When we get a patient with anxiety, we need to give a little bit more time maybe for explanations about treatments, so about what to expect so the patient doesn't feel hurried. Gradually introduce the patient to some more advanced and lengthy treatments over time. Being prepared to stop early if the patient seems a little over anxious. Give the patients ways to feel in control, so basically letting them know that that we're going to look after them, making sure they know if they just bob their hand up, we're going to stop straight away, etc. Sometimes we can offer alternatives, solutions at other practices such as sedation. Some of the other techniques available, things like hypnosis, etc., can be very effective for relaxation techniques, or even actually just encouraging a patient to bring some music and some earphones just to listen to while we provide treatment. Lovely. Obviously, we can refer on for dental health psychology if need be, and that's obviously through a registered specialist in that field.